In this part, we will discuss the classification, diagnosis, and detailed treatment of vulvovaginal candidiasis. Strictly based on Berek and Novak, Chapter 15, vulvovaginal candidiasis is classified into uncomplicated and complicated forms, and a subset of patients develop recurrent vulvovaginal candidiasis. This classification is important because it determines treatment duration and drug choice. Vulvovaginal candidiasis is classified into uncomplicated and complicated forms. Uncomplicated VVC is characterized by sporadic or infrequent episodes, mild to moderate symptoms, infection usually caused by Candida albicans, and occurrence in immunocompetent women. In contrast, complicated VVC includes patients with recurrent or severe symptoms, infection caused by non-albicans Candida species, and those who are immunocompromised, such as women with diabetes, HIV infection, or those receiving immunosuppressive therapy. Recurrent vulvovaginal candidiasis is defined as 3 or more episodes occurring within 1 year. A presumptive diagnosis of vulvovaginal candidiasis can be made even in the absence of fungal elements on microscopy if the vaginal pH is normal, the saline preparation is normal, and there is increased erythema of the vagina or vulva on examination. The gold standard for diagnosis is a fungal or yeast culture, which is recommended to confirm vulvovaginal candidiasis. Other diagnostic modalities include FDA-approved molecular diagnostic tests. Women with normal physical examination findings and no evidence of fungal elements on microscopy are unlikely to have vulvovaginal candidiasis and should not be treated empirically unless a vaginal yeast culture is positive. For uncomplicated vulvovaginal candidiasis, topical azole therapy is the most commonly used treatment. Short-course regimens lasting 1 to 3 days are preferred because they achieve high intravaginal drug concentrations that persist for several days. Recommended regimens. The recommended topical regimens for vulvovaginal candidiasis are as follows. Fluconazole is used as a 2% bioadhesive cream with 5 grams administered intravaginally as a single dose. Clotrimazole may be given as a 1% cream, 5 grams intravaginally for 7 to 14 days, or as a 2% cream for 3 days. Miconazole can be administered as a 2% cream for 7 days or 4% cream for 3 days. It is also available as vaginal suppositories, 200 milligrams for 3 days, 100 milligrams daily for 7 days, or as a 1,200 milligram single-dose suppository. Nystatin, although available, is less effective than azole and requires 100,000 units intravaginally for 14 days. Fluconazole is used as a 6.5% ointment, 5 grams intravaginally as a single dose. Fluconazole may be given as a 0.4% cream for 7 days, a 0.8% cream for 3 days, or as an 80 milligram vaginal suppository for 3 days. Treatment with azole antifungals results in symptom relief and negative cultures in approximately 82 to 90% of patients who complete therapy. Symptoms usually resolve within 2 to 3 days. Short-course regimens up to 3 days are recommended. The oral antifungal agent fluconazole, given as a single 150 mg dose, is recommended for mild to moderate vulvovaginal candidiasis and has equal efficacy compared with topical azole therapy. Patients should be counseled that symptoms may persist for 2 to 3 days after treatment. This persistence should not be interpreted as treatment failure. Women with complicated vulvovaginal candidiasis benefit from fluconazole 150 mg with an additional dose administered 72 hours later, or from prolonged topical azole therapy lasting 10 to 14 days. Adjunctive treatment with a weak topical corticosteroid such as 1% hydrocortisone cream may help relieve severe external vulvar irritation but does not treat the infection itself. Treatment of recurrent vulvovaginal candidiasis consists of 2 phases. First, induction of remission is achieved using fluconazole 150 mg every 3rd day for 3 doses. This is followed by maintenance or suppressive therapy with fluconazole 150 mg once weekly for 6 months. With this regimen, approximately 90% of women remain in remission during suppressive therapy. After discontinuation, about half remain asymptomatic, while recurrence in the remaining patients warrants reinstitution of suppressive therapy. All patients with recurrent vulvovaginal candidiasis should undergo fungal culture to identify non-albicans Candida and assess resistance to fluconazole. In cases of persistent infection due to non-albicans Candida, boric acid 600 mg vaginal suppositories for 3 weeks are recommended. Successful management of vulvovaginal candidiasis requires accurate classification, diagnostic confirmation, and appropriate antifungal selection with adequate duration, as emphasized in Berek and Novak. The next topic is atrophic vaginitis, an important exam entity, followed by inflammatory vaginitis,